So the next, we'll try to find. The next one is Professor Silverio Di Rocca. He has completed his degree in dentistry at the University of Buenos Aires in 1974. He achieved a postgraduate degree in functional orthopedics in 1982 from the University of Buenos Aires in Argentina. Collaborating in numerous clinics around Europe, such as in Italy, the United Kingdom, Switzerland, and Spain, as well as pursuing ongoing research and teaching activities through the MPR International School and in collaboration with other institutions. Without further ado, I would like to invite Professor Silverio Di Rocca to make his presentation.
Hello, how are you, everybody? I think you listen well my voice. Yes, it's okay. Yes, you listen.
Perfect.
Yes.
Perfect.
Thank you so much. Thank you so much for the invitation. It's the first time I've been here in the meeting. I'm very grateful to be here. It's a very international meeting, and I think we share knowledge about all the world. Okay, I will present. I will share my presentation. Let me go ahead. Let me go here and let me go to the presentation here. And I think now you see the presentation. Yeah, you can see that. Yes.
Yes, we can see it.
You see the presentation? Yeah. Okay. I see the presentation here. I don't know if you see the presentation. Are you seeing that? Yeah.
Yes, we can see it.
Okay. 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 I will. Today's very difficult for me. You know, I have 50 years working in dentistry. 50 years is a very, very, very long time working in dentistry, and I see a lot of changes in dentistry all around the world. I live in many countries. I work in many countries, and I am a special dentist because now I am dealing with postural diseases. And I want to talk today about something that is our craniofacial system, That is very important to understand why I am telling that. Craniofacial system. And the relation with the posture. Many, many years ago, I talking about in 2004, I was invited in one meeting in the north of Spain for a group of implantologists. I was listening to the talking before with the doctor, very impressed with the talking, and I was thinking, how can I explain the implantologists this concept? Because they look only screw teeth and nothing more, and was implantologists and technicians. You know, 1,200 people you have to talk in the meeting. And I started, I don't know what happened in my mind, and I started the conversation, the meeting, the presentation like this. I said, listen, tell me if anybody in the room have never had a failure in the treatment, please raise the hand. And everybody looked one with the other. And I said, listen, don't look around because always we have failures. Right? Everybody had failures in the treatment. Myself, you, the technician. And if we see in the point of view of the implantologist, we say, oh, technician doesn't do a good job. That's why broken the crowns. That's why it's failure to treatment. If it's in the point of view of the technician, they said, oh, the implantologists don't take a good impression, they don't make a position good of the implant, and then they both are together, they say the problem is for the patient. And because they don't eat well, they broken my restoration. I say, I think we never ask why we have a failure. And maybe it's because we have a different point of view in diagnosis. I born as a dentist 50 years ago, plus 7 years of university, 57 years, many, many years ago. I learned about teeth. Everybody is learning about teeth. Many years later, I start to do a very good specialization in this craniofacial orthopedics. I understand a lot of function in that moment, a lot of function in that moment. Very, very important. And later, I start to study posturology. Imagine, posturology. What is posturology? What is posturology? Posturology is a very important discipline. It's a medical science. It's a medical science that studies the posture. And in that moment in France, I start to understand the connection between the whole body. And I have a school. We created a school. It's an international school. It's called NPR International School because the protocol is the myofunctional postural rehabilitation. And we teach that for all medical sciences, from the doctors, dentists, physiotherapists, osteopaths, to work together. In that moment, I understood there was a connection between our system, which is craniofacial system, and the rest of the body. And in this moment, I said, something happened here. I was with my professor in France, and at that moment, I didn't know what is posturology. I said, I believe in you. Yeah? I think it's true what you say, but it's by faith because I don't have experience. But if you are telling to me these things that that was an orthopedic surgeon. You cannot work in posture because our craniofacial system are disturbing your job. And you said to me, I cannot do a good job. If the posture is not good, we have to start to work because I cannot treat the craniofacial system in one day. And in that moment, in my mind, I'm telling that 40 years ago, I start to develop a protocol to work together the whole medical sciences. And we create an association with the Swiss International Association of Posturology. I am the vice president of this association, and we're talking with all medical science to see the patient in the same point of view. And that's a little CV, just a little, that's not too long, but just to know what I am. I am a dentist, but I am a dentist who changed the mind to see the job. And I am not telling we don't have to be dentists. We have to do a good restoration. We have to do a good implant, a good teeth restoration. But the most important thing, in my opinion, is to see how our cranial system, craniofacial system can disturb the rest of the body if it is not in a good function. And that is, in short explanation, the topic of my presentation. We were talking about craniofacial system dysfunction. We were talking, I want to introduce you the posture also, because posture and posturometry, how we measure the posture, because that you will understand why I am telling that. I start to measure people in posturology in 1999. I measured more than 10,000 people. And I discovered what happens when our craniofacial system is not working well, how can disturb the posture of the body. And that's why it's important. I think, in my opinion, it's a very difficult concept to understand immediately. Many, many years ago, for me, was the same. But we are connected. We cannot work only the teeth, only the foot, only the eyes, only one part of the body. We have to work in the whole body. And that's why I create this protocol that is myofunctional postural rehabilitation. Why I am telling craniofacial dysfunction? Sometimes the people said, I'm specialist in TMJs. And imagine if I said to you, I am a specialist in a finger. What do you say? You're crazy, no? The finger is part of the hand is part of the arm is part of the body. TMJs is part of craniofacial system that is connected with the rest of the body. When I start to study posturology, I understood very well. That's why we dentists have to be more attention when we work, not just looking the teeth, not looking the TMJs, just looking the connection between muscle change. And I try in that small presentation, I try to explain synthetically why I am telling that. And craniofacial system. TMJs is temporomandibular joint. Temporalis is part of the cranium, and the jaw is part of the face. We are connected. And this joint is connected with the cranium, with the neck, and with the rest of the body. Sometimes I was listening with attention the research of the professor before me, and the research only look. I am orthodontics also, and I deal with orthopedics also. I worked many years ago with implants, and I did all the specializations in 50 years, imagine. I work in all the specialization from the decay until the rehabilitation. And then I choose craniofacial orthopedics and functional orthodontics. Now, I'm postural disease, that the things we are occupating now. But all the researches are looking at the teeth. And we don't look what happened with the rest of the body. And imagine, I am saying, when some teeth is broken, it's for something, dysfunction. If you don't absorb the fracture, it's broken. But sometimes it's not broken. But we study what happened with the neck if it's not broken, because it's resistance, it's still there. The same for orthodontics, no relapses. But we look what happened with the cranium, with the neck, with the rest of the body. The research in dentistry and in medicine don't put together these two situations. Even with the insoles, if a pedestrian do a research for insoles, never see what happened with the jaw position. Even the physiotherapists, when they do some treatment, they don't see what happened with the jaw position. And we, dentists, we don't see what happened with the rest of the body. Many years ago, I started to study that, and that's why I am very happy to talk about craniofacial system. Craniofacial system is a very important system. TMJs is just part of the system. We cannot say TMJs. It's craniofacial system. We said also craniofacial, cervical, and postural system. And it's a big disturber of the posture. Very, very big disturber. That is the thing I teach to my students all around the world. I teach for all medical sciences, but in dentistry, I teach that to explain that is very important. We have to create a rehabilitation imbalance with the rest of the body. Craniofacial system. No TMJs. Cranium and face connected with the hyoid system and the neck with the rest of the body. Sometimes, and I was learning orthopedics many, many years ago, also we do a change of the jaw position to stimulate the growth, because we have to do a therapeutic change of the jaw position to stimulate the growth. What we never see, if they change, is accepted for the rest of the body. And also there, we can create postural problem. In a child, it's very important. In a child, I focus on the child, because in the child, you can prevent the future with craniofacial orthopedics. And when we have in harmony the craniofacial system with the rest of the body, we have good posture, good muscle change working, good health for the patient. But what means that? We means a good jaw posture with the rest of the body. I started to work in dentistry, as I told you, 58 years ago. Our meaning is the central relationship. Central, and you have a lot of definition, central relationship, but nobody said the central relationship with the rest of the body. Central relationship only with the jaw. And we cannot have a good central relationship. We cannot have a good vertical dimension if the body is not in balance with us, because we will have also something who is against us. We see the effect of on a static posture. To do that, to understand that, I have to explain a very, very synthetical notions about tonic postural system. Imagine, tonic postural system. Tonic postural system is a very important system. Our body needs the basic tone for the muscles to have the skeleton in balance. And we have a system with the main director is the central nervous system, who have a peripheral receptors who send information to the central nervous system. He elaborate the situation of the environment and create a muscle tone of the body. Imagine, muscle tone of the body, craniofacial system have muscles as a body, neuromuscular system. And that's information is arriving through the main receptors. We have a good antenna in our body who arrive the information to the craniofacial system, the central nervous system, sorry. Mainly the oculomotor system with the movements and the foot support. Obviously, it's more complex than that, but I try to simplify now. We send the information from the top to the bottom to the brain make the tone. Muscle is an effector, but also a receptor, and sending back the information, and it's creating a cybernetic system, a closed cybernetic system who never stops, even if the information of the receptors are wrong. Imagine if the foot support is wrong, if the oculomotor system is wrong, and the other receptors sending wrong information, the answer is wrong, and we create an adaptation. Some of the scoliosis, they are functional scoliosis related with all the things I am telling you. Just 5% of the scoliosis are structural. And in the middle of the receptors, we have a craniofacial system, the stomatognatic system, which is a big disturber of the posture, very, very big disturber if it's not in balance. Oculomotor system is movement. When we have a good movement, we have good peripheral vision. This is a research I did many, many years ago, 1999, checking what happened with the jaw position, and please focus that. Jaw position, central relationship. When it's not good, it's creating alteration of one of the main receptors, who is the oculomotor system. Lateral deviation are creating, we call hypoconvergence, unilateral hypoconvergence. And the forward position or retro position are affecting both eyes, creating bilateral hypoconvergence. And when you say, why you study that? Because that, these situations is creating alteration of the posture, overload, lateral, right or left, and changing of the very center of the body. Craniofacial system is connected with the yoids system. Yoids system is a special system in the middle of between cranial, neck, and body, who is connecting the whole body. And as you see, functional scoliosis is related with the mouth, with the foot, with the eyes. And what is the relation with the static posture? How the craniofacial system is affecting with the changing of the position. That what we are focused forever, dentists, in the central relationship, and we don't know why. We say we have to do that because our rehabilitation have to go in a good relationship. This is good, but this jaw position, we have a position that not affect the rest of the body, and that's important. Yoids system changes in the mandibular position when the jaw position is, here we have to talk a lot about PMJs, but I try to simplify. When the jaw position is not good, our temporomandibular joint is resisting mainly the traction, but it's not resisting the compression. Most dangerous also if the compression is on the back, when is arriving the whole innervation and irroration of the temporomandibular joint. That's the life. And the central nervous system have a defense. They said it's an automatic defense. The teeth are blocking a jaw position, which is wrong. This is dangerous for the joint. I have to destroy the teeth, bruxisms. And it's a very bad defense because it's creating more problems. But it's a defense automatically. Bruxisms is not a stress. When something is not working into the joints, into the temporomandibular joints, into the sorry, this is starting here. This is starting here the telephone. Okay, when we have the jaw position changes, in that moment, the brain said defense. We have a particular receptors, mainly in the back of the joint, who send information and say, something wrong for here, please destroy the teeth. More if the vertical dimension is loose, more if the occlusion is very bad, if it's not functional, destroy it. That creating muscle hyperactivity, cranial muscle hyperactivity. And slowly, slowly, it's going down, 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 and it's altering the whole muscle change, and it's creating postural and chronic alteration. Perhaps that's happened later. That's why I am fanatic in the prevention in childs when they are growing, to work in this interdisciplinary concept that is interdisciplinary. That system, when starting in the moment that when the system start in the moment. Oh, sorry about that. Is something I don't I don't put the telephone off. There's some of my friends who is trying to talk with me. And sorry about that. I was checking with the tablet if the transmission is good, and I forgot to make in silence. And coming back to the presentation, I am telling that if we have chronic alteration, that happened after 40, 45 years, when the symptoms appear. And that dysfunction we never see. We see when it's late. The jaw change position is dangerous for the system. It's an alarm saying teeth are blocking that position. Here is danger, and we are creating bruxisms. And slowly, slowly from the top to the bottom, very slow, many chronically, we're starting to create a disease in our body, postural disease. That's why we said craniofacial system dysfunction is a big disturber of the posture. But we never look about that. We look only teeth, jaw, TMJs, but not see the rest of the body. And even the doctors and the physiotherapists, they don't understand the craniofacial system. And we cannot work together. I create a protocol with the same point of view, with the same protocol to work together, to speak the same language, and to speak. It's very complicated because here is more things, not only that, but it's very difficult in short time to explain that. But defense, bruxisms is not a stress. It's a defense, very bad defense. Bruxisms start the domino effect that slowly, slowly is creating chronic pain and injuries. The common misconception is that bruxisms is a stress. It's very wrong. When I am stressed, I put the teeth together and force. I say, I won't kill my grandmother. My grandmother was a very nice girl. I put the teeth together. Bruxism is random. Bruxism is creating later stress, but it's not creating bias stress. Bruxisms cause stress chronically, but it's with the parafunction. They are testing the teeth occlusion. If the functional areas are good, if the vertical dimension is good, if the muscles are good, if it's not, they say, okay, these are the lock who are creating problem in the TNJ, we got to destroy the teeth. Very bad defense. And how affect the muscle? Hyoid system. When something happens on the top, we have the connection with the rest of the body. The upper hyoid system and the lower hyoid system. And slowly, 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 we are going from the top to the bottom, creating alteration. This situation is very bad. This is the most dangerous situation, retroposition. And even if we have lost the vertical dimension, and even if we have a very bad functional occlusion, that is creating hyperactivity with the bruxisms there. First, slowly, slowly block the neck, upper and lower neck, and we started with headache, decisions, pain in the body, pain in the muscles, block the neck. And we go into the physiotherapist. No, we don't know. The main problem is in the jaw. The changing of the position, this is very bad. And the most dangerous situation is the retroposition with vertical dimension. Is creating slowly, 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 with the bruxisms trying to eliminate the position, hyperactivity. And this hyperactivity going down, down, down slowly. We do a craniofacial diagnosis, it's obvious. Mandibular posture, dental occlusion, and neuromuscular activities of the oral corridor. We study TMJs, muscle teeth. We are not studying the craniofacial system, but also we study the body. The jaw position centrated. But more than that is the vertical dimension. And we said in our school, We have a neuromuscular postural vertical dimension and anatomical vertical dimension. Very short time to explain that now. We have two vertical dimensions. They have to be in coincidence to do not affect the muscle change. Obviously, jaw position, bad jaw position, teeth, muscles, etc. We studied the occlusion, obviously. When we found, we studied as a dentist, we studied the occlusion, the postural plane, we studied the movement, the guides, all. But the first thing I said before studying that, we have to put in balance the whole body. And then, when it's in balance, we have to have a good local diagnosis. If it's not, we lose the point. If we look only this, we have to first, and that's why in our protocol, we said first deprogramming, rehabilitate the body, and then reprogramming the jaw in balance with the body, and then study the occlusion. And then you will have a good occlusal analysis because the jaw is centrated, the muscles are in balance, and you can do a good dentist to study the occlusion. The guides, the muscles, we study buccinators, lip, chin, stony, and breathing. All these have to be in balance. We do a postural diagnosis. We shortly I explain. We do local diagnosis and we do a postural diagnosis. We study the whole posture, the oculomotor system, the foot support, the muscle change, etc., etc., etc. Very short time to explain that. We see if we have a good balance between one part of the body, if the neck is functional, if we have a good function in the eyes, if we study the foot support, if the foot support is creating problems or not problems, and then we measure. We have an instrument, then we can measure. The instrument with posturometry and stabilometry, we can measure the clinical. I was studying with the Dr. Bernard, not in Seattle. He said to me a very important phrase. He said, the clinical opinion can be true or false, but it's just an opinion. If we can measure, we transform it in science. And we measure the posture to transform our opinion in science. This posturometer is a very important device to study. If we are in balance, the whole body is based in different analysis of the very difficult to explain posturometry now, but we study the Kapanji concept, we study the body weight distribution in the floor, in each foot, and we have different situations that we can study, analyze. We call that clinical posturometry. And look at that. This is important research I did in 1999 because I was curious. And I want to see what happened with the pre-contacts in our teeth. Change the jaw position, obviously. If I have a pre-contact, the jaw position has changed. And I want to observe, measuring with the posturometer, what happened. And was a very surprise, because 98% of the patient, we create pre-contact with acrylic, with composite in each tooth, and we measure what happened. We create pre-contacts in the anterior guide, in the occlusal plane, and in the, we call the curve of speed, the posterior guide, and we observe what happened. And any time we measure with the posturometer, any pre-contact in the anterior guide, canine and incisors, make it lose weight in the first foot metatarsals. Immediately is affected. The pre-contact in the occlusal plane is making lose the weight homolateral in the fifth metatarsals. And in pre-contacts in the curve of speed or posterior guide is creating loose charge overload in the calcaneus. like this. The first area, occlusal line, and curve of speed. Very interesting, the results. And then when we study that, we said how we treat it, the patient. Occlusion is very important. We said occlusion is the last. The professor said implant is the last. I agree totally. Nothing better than the teeth, nothing better than the normal teeth. Nothing at all. But always the occlusion. Occlusion is the last I have to treat, not the first. Because we have a lot of influences of the muscles that can affect our central relationship. And that's why in our treatment, we said, first, annulate the mouth. We create some particular device, a very simple device, that annulate the occlusion for a short time, is calling that deprogramming. When we obtain the deprogrammation of the jaw, we can have a good body rehabilitation. And then we reprogram the jaw, any technique. We call that the progressive jaw reprogramming, because in the body have to be slow. The reprogramming, progressive reprogramming of the jaw. That means founding the central relationship and the vertical dimension, the neuromuscular vertical dimension. And in that position, we study what to do with the teeth. That is our protocol. The bed device is a simple thermoplastic. I invented that 20 years ago. It's a thermoplastic, very simple to use, that you adapt in the body of the patient. You have to be trained for that. They use during the night, annulating the occlusion and slowly muscle change and jaw position deprogram. When we do that, we can do a good physical rehabilitation. That's why I call it bed, to make the difference between a biplane. It's body equilibrium device. It's a device for the equilibrium of the body. It's a very different concept. And then we start slowly to make the reprogramming, founding the vertical dimension, and then after that, we do the occlusion. Right? We make the registration. Always we use articulator, so the tools in dentistry. We change the concept, how to work. I don't invent nothing in dentistry. I teach my technique in orthopedic, if you like, but dentistry is good. But when we act, in my opinion, is wrong. And then when we study the occlusion, what we have to do, if we have to do orthodontics, if we have to do prosthetic, if we have to do something to make a good analysis of the occlusion with all techniques. Today 3D is helping us. We use a lot of technologies, but we change the concept on diagnosis. Don't see first the teeth. And then we study. This is, and then we finish. I don't want to be more stressful. We have a patient who have, look at that, a real short leg. We have a side mandibular deviation, and we see what happened. Look at that. This is real. Yeah. If we don't change it, the muscle change is working bad, and it's making on the top the bad information and can change the jaw position also. Chronically, not now, chronically. And then this short leg, lateral deviation, vertical dimension loose, guides are nothing, we have nothing with occlusion. And when we do the measure, look at that overload, 4 kilos of overload to one side, related with the lateral deviation of the mouth. The loose of the overload, the body center is moving, absorption of the body. We can measure a lot of things. We are overloading the foot. and the colors. When the colors are not green, they have some alteration. Just to explain shortly the posturometry. And then with the bed device and a very short insole to correct the short leg. That was the treatment, just to show you how well can influence in the body. And that's the result, 0, all green. 0 unbalance, all triangles green, normalization of the posture, and we can set now, the body center is good, then the whole areas are green, the pangea, normalizing, and before and after. How the mouse can affect the posture. That I want to show you that. How the jaw position can affect the posture, and we can, if we annulate that and if we correct, the body is good. Prosthetic. Also, patient with vertical dimension loss. We do deprogramming, reprogramming, and then the rehabilitation. We found the vertical dimension, we measured the vertical dimension. Look at that, 14 kilos of overload, this patient in the body. Look at how can affect the body on the body center. We change it with the restoration. That's why we measure if our vertical dimension is not affecting the body. Another patient with also the vertical dimension loss, bruxismus, a long time bruxismus, and then we make the rehabilitation and we change from 5 to 2 kilos. This is our courses in our school. We have an international school, and this is just to show you the connection between craniofacial system and the rest of the body. And I believe the whole medical sciences need to understand that. That's why in our school we teach for all of them. It's more complex than this. In this short time, I cannot explain the whole protocol. We study alimentation, biochemistry, etc., etc., the CIES, a lot of things. But in the short time, I try to explain shortly the connection between how our craniofacial system can disturb the posture, and we dentists have to work together with other specialties, not just alone. We need the collaboration, and to work together, we have to speak the same language in diagnosis and therapy. That is NPR. Speak the same language to work together. The holistic and interdisciplinary protocol. Medical sciences in the last times is alone. Everybody look at the patient in their point of view. And I believe that the point of view is an interdisciplinary diagnosis, an holistic diagnosis to work together. If we work together, it's good for us and it's good for our patient. I hope you enjoy the presentation. Let me go back to the meeting. Okay, I hope you enjoy the presentation. It's very complex, the presentation to explain in 1 hour, but I hope I be clear to all of this. Okay, if you have any question, I am here just to answer the question. All right.
Thank you very much, Professor Di Rocca, about subject which is very important, craniofacial dysfunction, which is very important for the health and the well-being of the people. You know, this is very, very important issue. And also, if I may...
Thank you, Silverio, for your very interesting presentation on posturometry. Thank you.
Thank you so much for the invitation. I'm very grateful to be here every time. A very, very good meeting. Thank you so much.
And the thing is, you know, all these craniofacial dysfunctions, prevention is the best cure. So earlier the diagnosis and the treatment, and easier the treatment, better is the treatment, instead of waiting the last minute and to make the treatments. And this is an issue which is in relation with the treatment, the treatment of this kind of dysfunctions. And I'm sure that whoever is watching appreciates all the small details that you made based on your 50 years of experience. I have almost as much of clinical experience anyway. So I appreciate what you went through during all these years, all these, periods of dentistry, improvements of dentistry. Thank you again.
Thank you so much. Thank you so much for your invitation, and I'm very, very happy to be here with all of you. Thank you so much.
We appreciate you. Thanks.